It depends on who it is.
So give me if there's one thing that somebody takes away from all this, if they didn't hear anything else, what's something that I, as a strength coach, need to um, have as a constant when it comes to a tendinopathy? What do I need to have as my um, foundation and to stay in my lane and to also like what is your one piece of advice that is consistent across the board for tendinopathy for strength coaches if in fact they come across these issues that have so much what ifs to them.
Sure. I would say first thing is don't try and diagnose it to the patient, right? Don't try and tell, well, I think you have this. Like, no, that's way outside of the scope. So
Mm-hmm.
saying, you've got basically, man, when they basically bring their arm out in external rotation, like that's irritating. Like you can kind of make some guesses to the best of your knowledge and best of ability in that certain case. So don't try and diagnose. B, most tendons will respond well to education, unloading, reloading in an appropriate manner, and then preventing those further injuries by basically strengthening up and load management. A lot of times they will get better with load management. There's always that it depends model, but if you're going through and you're using the 2-point scale and you're keeping in mind that tendons, the behavior is that potentially during exercise, 30 minutes to an hour or sometime later, and then that night is typically when those tissues are going to be irritated. So you need to check in with that individual, that client, when they
Mm-hmm.
come in next time. Don't just assume that they were okay because they didn't have any issues when they were with you, and that your load management is perfect because they didn't have any issues in session. We need to be asking as a strength coach, how did you feel that night? And if the answer is, man, I could not lay on that shoulder, it was really bothering me, then you need to look back at load management and say, I did too much. What did we change? And then make an educated guess to basically back off and then reload from there. If that,
Excellent. Excellent. Yeah. So one last question. I promise it'll
no, you're
we'll
good.
we'll
This is
we'll
good.
end it. So if I was glad that you brought up the biggest thing is don't diagnose, right? Strength coaches love to, for some reason, a lot of them that for whatever reason just want to flex their guns, or maybe they're trying to compensate for their inability or whatever the reason, but they love to show off their kinesiology and their biomechanics and try to diagnose somebody with this, that, and the other. And I think that's a slippery slope of either paranoia or false confidence. And either way, they're both polarizations and they're both inappropriate. Um, and I think that a lot of times, that it's the cocky strength coach like that sees it as a sign of weakness to just keep their mouth shut. Keeping your mouth shut doesn't necessarily mean that you're ignoring them and have a deer in the headlight looks and you're scared. It's just what you said. It's just staying in the lane, being cautious and confident, and then making adjustments. Um, the other thing that I wanted to bring up, is it useful to you, for since we have this information now that you've given me, would it help you if it comes to the point where the client's coming to see you, now that you've given me this information, would it help you in your process with them if I told you, like, hey, I've this has been going on for 5 days. They do have pain doing this movement. I did talk to them 6 hours in, or 24 hours in, they were fine, but 6 hours in, they were hurting. Would that kind of information be helpful for you, or is that something that you're going to figure out on your own anyways?
I think that information is crucial, in my opinion. I think if you have somebody that you've been working with and they've been monitoring a load, honestly, if it's a strength coach that has not been monitoring load and they want to try and give me their answer or give me their guess, I don't care. I really don't. Like that sounds
Gotcha.
rude, but if you haven't been monitoring their load and you're not actually paying attention, you're just like, oh well, their shoulder hurts with this, and then it's like, well, what's the load been? We just throw this number up on the board and they just kind of do it themselves. If you're not monitoring it, do I want to know? Yeah, squat's hurting them, or they did this. To some degree, yes, but I would much rather know, like, hey, we backed off on some of the load. Here's what they're doing, not only from a diagnostic and understanding standpoint, but from this patient is super strong. They're already doing all this. I
Mm,
don't need to give them all this basic crap anymore. Like,
mm.
maybe a little bit to back off and see where they're at, but maybe I diagnose, try and figure out what's going on, see what contributing factors are going on, and then I can be like, hey, Aaron, look, man, she actually was having a knee issue because she had this, whatever, right? Or it's actually, I think this is what's going on. Here's how we need to move forward as far as degrees of motion and open kinematic versus closed kinematic or whatever, depending on the particular tissue and what region it's in. So not only does it help from a diagnostic standpoint, but it helps from I know this person a little bit better. This is someone who has been doing a strength program for 3 months or for a year, or this is a beginner, and maybe have the conversation with you. But I think if it's someone who hasn't really been paying attention and all of a sudden they just say they've got shoulder pain, I'm like, and so I do want to know the details. I do want to know the lifts.
See, that was really good. That because and again, it's eye opening because I'm not in that position. And so when you're in your zone, everything's always the basics are assumed. So what I mean by that is your simple statement that I wasn't even trying to go that route with, but you just opened my eyes with, is like, you need to understand who you're dealing with, right?
Yeah.
When they're coming to you. For me, like, yeah, I see Joe Smith. He's my 400 squatter, and Jane Doe is my 150 deadlifter. Like I already have this constant, continual snapshot of their levels and their ability. But when they come see you, you don't have that physical view. You don't see them in action. So I think that's a great point that you brought up. Is getting a snapshot of what their abilities are, so that what I assume is when it does come time to prescription of movement and modalities, you can give the right dosage.
Don't oversimplify it, right? I mean, right. If so, let's say for Jane Doe coming in who can do A, B, C, D, like she can deadlift, and she's deadlifting for reps 175. She's doing great. Like, she's really progressing in her program. Just think about just loading principle in general. We both know that if you back off way too much, there's atrophy, and if you go too much the other way, there's injury. And I think that's what I keep in mind is, wait a second, where is the unloading phase for this individual? Is unloading for them
Bingo.
Just going and saying, well, let's just stop, period? No, like, you do that, and now it is a long road back. Now, do we make adjustments and say, hey, you're having some knee pain that's bothering you with some squats? If you change it to this type of squat, was it better? Yeah, it was fine. All right, great. I want you to back off a little bit on whatever, but let's not back up all the way to the point of we're not loading you or giving these tissues any kind of stimuli.
So as a physical therapist, it is critical to understand their level of conditioning and strength. And correct me if I'm wrong painting this picture. If you undervalue how strong the person is, and with that undervalue, you prescribe something that's such a low dose that they do start to atrophy, not only is that probably not helpful, but that can almost be counterproductive, right? Because atrophy, when we talk atrophy, we're not just talking the muscle, we're talking the ligaments and tendons as well, all the structural components that have created that.
Support potentially, yeah. And so I'll give you an example. There's a